Okay, so it's 6 o'clock here in Munich. Hello, everybody, and welcome to the webinar about the evolution and versatility of MicroPulse Transscleral Laser Therapy for glaucoma experiences in Europe. My name is Marc Mackert from the University Eye Hospital in Munich, Germany, and I hope you are all well in these difficult times. And I think it's a great and unique opportunity to have this platform for sharing ideas and exchanging knowledge about transscleral laser therapy. Now I would like to introduce the today's speakers and leading experts in this field. So I have with me Professor Aptel from Grenoble, France. And then we have Ronald De Crom from Maastricht in the Netherlands. And from Zurich, Switzerland, Marc Töteberg-Harms. Welcome, everybody. So after a quick overview, we will discuss the benefits of non-incisional therapy and the versatility of MicroPulse and translaser therapy. And up to date, we will share how it can be used during COVID-19 and early experiences with the revised MicroPulse P3 device. And at the end, but also in between, if you have any questions, you find on the bottom, there is a chat button, so you can directly type in some questions if you have, and then we will discuss them in between or then at the end in a roundtable setting. So let's start with a quick overview, if that's all right for you, about transscleral laser therapy. I hope you can see my screen. Well, these are my financial disclosures. The lecture is sponsored by Iridex. Treatments of glaucoma, as you know, mainly target the lowering of intraocular pressure, which is the only modifiable factor in glaucoma's disease progress. And glaucoma patients are usually initially managed with medications or laser trabeculoplasty before more invasive ocular surgeries such as trabeculectomy or valves are used. A broad range of minimally invasive glaucoma procedures have filled up the gap in between. Traditionally, transscleral laser cyclophotocoagulation since many years have been very effective in lowering IOP in patients with refractory glaucoma and was used as the treatment of last resort due to the destructive effect and the significant complications. So here I would like to show you a Miyake Apple View video of the standard continuous wave cyclophotocoagulation. And what happens sometimes, if you're familiar, you can hear a pop effect during the procedure. And what happens, you can see in this video. I started now, so please have a close look. Bam. So this is the pop effect. This is the result of collateral tissue damage from the spread of thermal energy. Usually, with this procedure, we perform here about up to 30 single shots with 2000 milliseconds and 1650 milliwatt to treat refractory glaucoma. So with the development of a novel approach known as MicroPulse technology, a series of repetitive short bursts of laser energy are delivered in an on and off fashion to the ciliary body. During the off cycle, the adjacent non-ciliary structures are allowed to cool down and protecting them from thermal damage. This approach reduces the destruction of the surrounding tissues. So here, results in less inflammation and fewer complications without compromising the IOP lowering effect. So this is again a video you can see of the effect of the MicroPulse TLT. So I started now, please have a close look. So this is quite different to the continuous wave cyclodiode. Usually the probe is moved in a continuous sweeping motion over 360 degrees for 160 seconds with 2000 milliwatt, avoiding the 3 and 9 o'clock position, as you know, where neurovascular structures may be injured. The exact micropulse effect is not fully understood up to now. But it's very interesting, this experimental video from Murray Johnston, which shows very nicely that this is not a cyclodestructive procedure. So you can see in the video here what happens. There's a slight shrinkage of the ciliary body, causes the tissue to pull on the trabecular meshwork and Schlemm's canal, and opening the drainage system enough to facilitate greater fluid egress and therefore pressure reduction. So let's talk a bit more about the surgical technique of TLT. Marc Töteberg-Harms will later talk more about the anesthesia options you can use in these patients. Usually I use a wired speculum, something like a Barraca speculum, and sometimes it's good to use no speculum at all for enough space to place the probe. Sometimes it's helpful when you, for example, have a retrobulbar block, and then you cannot really, you don't have that many space to place the probe. I use oftentimes a squint hook to guide the eye. I'm not sure if the others do. And always use something like methyl cellulose, so a viscous fluid interface for the coupling, because when you don't use it, you lose up to 30% of energy loss, really. So it's not only for moisturing the conjunctiva and the cornea, but it's also to get the full amount of energy. And use adequate pressure when delivering the treatment. Here you can see the different techniques of the Gastelum probe, the G probe on the left side, and the MicroPulse P3 device on the right side. With the G probe, you apply single shots around the circumference of the limbus. After you located the ciliary body, you can use the transillumination light to really show where the ciliary body is. And the probe is placed parallel to the visual axis. With the MicroPulse on the right-hand side probe, you do sweeping motions across the superior and inferior hemispheres. And the probe orientation is perpendicular to the globe. So aim the probe with the MicroPulse towards the center of the globe, and the flat side should be directed towards the eyelid, and place the edge on the surgical limbus. Apply adequate pressure like a pen for the procedure, and usually I do 5 passes per duration for both hemispheres, and a second for hemisphere and 2000 milliwatt. So here is a video. You can see the MicroPulse in action from Ronald De Crom. And you can see how slowly he is really moving the probe. I use a bit more viscous coupling, not drops. And you need to moisten the conjunctiva, otherwise you can tear it sometimes when you have old people with thin conjunctivas. And then try to avoid the 3 and 9 o'clock position. And as you can see, he's not using a speculum. This is sometimes more comfortable. And then you have more space to place the probe. So this is a computer simulation of photon dispersion when using the original MicroPulse P3 device on the right-hand side. And on the left-hand side, you see the revised new probe, which will Marc Töteberg-Harms later talk about. And you can see that it is not really a laser spot. It's more like a cloud of photons being delivered. And it can be up to 2 millimeters wide at its widest point. And that's why this technique is so important, to ensure that we are delivering all the energy to the desired tissue. So what is the treatment regime after the operation? I usually use hydrocortisone ointment with a patch, or if it's only seeing eye, you don't use a patch, of course. Some surgeons I saw, they use atropine to ease the ciliary pain. I don't use that personally. And then the day after, we prescribe prednisone acetate eye drops 6 times a day to taper down every 5 days. And for me, there is no need to put any antibiotics because we're not opening the eye. It's treatment on the surface. And so with the MicroPulse technology, we have less complications and the treatment options have really broadened. So we can use them from mild to severe glaucoma stages. And we can adjust the energy levels depending on the glaucoma stage and the pressure. So we have the G probe to apply continuous wave cyclophotocoagulation for treating refractory glaucoma with cyclodestruction. And with the MicroPulse TLT, we have an alternative treatment with ciliary muscle shortening and outflow pathway reorganization. This allows to treat more stages of glaucoma from mild to severe without any serious complications, but with the same pressure lowering effect, actually. Thank you very much for your attention. So I'm not sure if there are any questions at the moment. Otherwise, I think we will just continue with our talks and then try to see what's open afterwards, open questions in the discussion round. So next topic will be the evolution of MicroPulse TLT. And we have Marc Töteberg-Harms, and he will talk about this.
Yeah, thanks, Marc, for the introduction, and thanks everybody for joining us tonight. Let me show you my screen. So these are my financial disclosures, and as well, I have received lecture fees and travel reimbursement from Iridex, which is related to this talk. So let's talk a little bit about the MicroPulse during this COVID-19 time that we are currently in. It's a very challenging, and especially because nobody of us was really prepared for what's coming or what has come and what's happened. I mean, the last time we have seen something like this was nearly 100 years ago, and that's so long ago that nobody had any idea what to expect. A little overlook what happened to us here in Switzerland. We had a couple of weeks where we were forced not to see any patients. We were locked down by the government. We're only allowed to see urgent emergency care cases, especially cases when you not treat them, they would suffer any damage to their eyes, their health, that could not be So why was the government doing that? The government was trying to keep capacity in the hospitals available in case we would see a peak of cases, as we have seen it in China, Italy, Spain, and we see it currently in the US and in Brazil. We were lucky that this didn't happen here in the north part of Switzerland, at least, but for 6 weeks we were on lockdown. I know similar regulations and recommendations have been in place or are in place in many countries over the world. And we got lucky, as I said, like the numbers in the north of Switzerland didn't peak that much. And at the moment, the reproduction rate of the virus is lower than 1. So the cases are going down. And I looked it up yesterday. We had about 10 cases, new cases. So we're very, very lucky that we are kind of getting over the situation here. But personally, there was a fear. There was a lot of fear involved in this lockdown situation. The fear of being infected personally, being in fear that your family members of your team, your work team, your friends and your patients could be infected. There was also fear of not seeing patients, not being able to care for them in the way we're used to. And also we were concerned of being the patient number 0 for family members, friends, patients, and to infect them potentially. However, we all adapted kind of to the situation. And something had changed in my practice at least, and I think that was pretty similar to what you have experienced in your private practice, in your hospitals or in your settings. Slit lamps are now equipped with a plastic shield, technical equipment, OCT machines as well. Usually nobody is using at the moment air tonometers anymore because of aerosols that could potentially be formed. Face masks, protecting goggles, gloves are present during our clinics at the moment. It makes it sometimes to get interaction with the patients, to be close to them. So, to ophthalmology at all, this COVID-19 pandemic? Well, SARS-CoV-2 has been found in the tear film, especially in subjects with head conjunctivitis, but there are single reports also from other patients without any ocular signs that the virus was being found in the tear film. It's still unclear if the virus is actually produced in the conjunctiva or if it was just some contamination by rubbing. Potentially the virus could also be in intraocular fluids. So if you perform surgery, there could be some aerosols spilled during phacoemulsification or during vitrectomy that could infect you, your team members in the OR. So what we established here was a pre-op testing. And if the negative in those cases, personal protective equipment was sufficient, but all patients got a preoperative testing before any intraocular surgery. Iodine is very effectively killing the virus in a concentration of 5 to 10 used in ophthalmology. If the pre-op testing was positive, you have to use an N95 mask. In addition, eye protection, face shields, and you also have to take into account that the OR theater needs sufficient time for air exchange. So in our hospital, we usually wait between 1 and 2 hours between surgeries of COVID-19 positive patients. So you can't do as many patients during a day as you were used to. My personal experience, well, by not being allowed to see patients, the volume in my glaucoma clinic dropped by approximately 50 to 60%, but the surgical volume dropped by amazingly 80%. The biggest problem was that elderly patients were scared to be seen in the hospital, so they don't want to come in that often as necessary anymore. But on the other hand, you have to treat some of them. So we try to minimize numbers of consultations for our patients, and we had to change the algorithm accordingly. So that's my usual algorithm, and there's something similar that Marc from Munich showed you before. We start with drops, we go over to lasers, SLT and ALT, we wait a little bit, maybe perform a mixed procedure in the middle, then we do microdestruction. During this COVID pandemic, Iridex provided us with a new generation 2 MicroPulse probe, the revised probe. And we could use it in this paradigm change in our algorithm. So nowadays, sometimes instead of doing ALT and SLT, we do a MicroPulse procedure in this gap time instead of mixed procedure, MicroPulse TLT. Sometimes even to avoid or postpone a trabeculectomy, and maybe even after trabeculectomy or after tubes, we do MicroPulse TLT in the current time. So my take-home message for this COVID-19 pandemic is the MicroPulse device enables us to offer our patients something that we can do in the office. We can do it immediately and thus avoiding a second consultation. Also, the post-op treatment regime is really, really simple compared to trabeculectomy. So you don't have to see the patients that often. And that really is what the patients want at the moment. They don't want to be seen that often by you, especially if you work in a hospital. The safety of the MicroPulse allows us really to use it at an early stage of glaucoma. Not like G-Pro procedures where we destroy tissue, where we have to be concerned of safety. We can offer this treatment earlier in the stage of our glaucoma patients. Because the efficacy is there, we can discuss this to postpone fistulating surgeries. We do not generally expect serious complications, so thus we can minimize post-op visits to usually 1 at 1 month post-op. And the outside of the laser machine can be cleaned with isopropyl alcohol at 70% concentration. Also the foot switch and the hand pieces are non-disposable. That makes us really use during this time, even in the office, not in the OR only. So let's look a little bit at the revised MicroPulse P3 device.
Marc, can I just, sorry, this is interaction here, and I just have a question about the COVID-19, a bit, or more like a comment.
Yeah.
Someone who says this is an excellent technique in COVID-19, and they use it with a really surgical drape. So I think it's important maybe to mention also the drape. How do you do the draping? Do you just do you do a full drape because of the breathing of the patients, or how do you handle it?
So our hospital policy is that every patient, when they enter the hospital property, the land, they have to wear a face mask. And that's usually sufficient for them if you think about aerosols to keep them away from you. If you also wear a face mask, you're kind of protected as well. There's not a lot of sufficient data on that, but probably if both person, the patient and you are wearing a face mask, you can potentially minimize contamination or infection by COVID-19. So I don't use a drape, I don't use a full, and I usually don't use an N95 mask in general.
Thank you.
Okay, I just wanted to go again to the hand probes. So I show you a picture of the old hand probe, and we have seen this in the first presentation as well. It's kind of like a pen. You have a flat side, and you have on the opposite side a small notch. The notch goes to the limbus, the flat side goes to the lid. And you can either do it with or without a speculum, doing the small swipes in the superior and the inferior hemicircumference for the desired time. Let's go over that because you saw that already. So with the revised probe, there was a lot of design changes made that were done by a lot of input from surgeons. And the problems we had with the generation 1, with the older hand probe, was sometimes it's a little bit difficult to enter the eyes, especially if the eyelid opening is very narrow or the eyes are very deep in the orbit. So they introduced this nice thin stem, and also the foot plate now has a curve that matches kind of the curve of the globe. So I show you that in the next picture. You have this little bunny ears that now go to the limbus. You have a little channel that's filled with the fluid, and that's very important, as we've seen before. for taking the laser that comes out of this small fiber and keeps the laser light in a straight bundle and not to spread laser light and lose energy. And you also have this curve over here that matches the limbus, and you have the curve of the foot plate. I show you that in another picture as well, that matches the curve of the eye as well. What stays the same is you do the swiping motion in the superior and the inferior hemisphere. And again, bunny ears go to the limbus, curve matches the limbus curve, and now you see the slight bend of the fiber tip. Fiber comes out here in this fluid channel, and you have this long, thin stem that allows access to mainly all eyes you want to treat. And also by this bending of the fiber, it's really easy to access, because if the eye is lying further down in the orbit, you have no issues with the orbital rim. You can use your finger to open the eyelid and then do the swiping motion. You have to find out if you want to stand temporally or superiorly. It depends a little bit what's more comfortable for you. I personally don't use the speculum. You can see a video here of the swiping motion. You put the foot place nice to the limbus and you go around, and you see you don't really need an eyelid. The small stem, the foot plate, open the eye, and you always have nice access and nice visibility of the treatment area and the surrounding area. What has changed a little bit now is the recommendation to only treat 50-second frames. So you do 5 passes, 10 seconds per pass. That's a really slow motion, and you have to get used to that a little bit. But you can orient yourself to the limbus, take all your time. You can always make a pause and continue treatment if you feel uncomfortable and think you have to reposition the hand probe. So let's talk a little bit of anesthesia. What kind of anesthesia protocol is sufficient for this treatment? Well, you can do subconjunctival or subtenon anesthesia. You also can do a retrobulbar block. So all kind of these standard procedures are sufficient for MicroPulse laser treatment in glaucoma. Analogous sedation is something that was very often done in Switzerland. Propofol, thiopental, and fentanyl is also possible. It's very nice for the patient because they sleep for 2 minutes. They don't recognize anything of the procedure. You do the procedure comfortably without any interaction of the patient, but it's not really necessary. I nowadays changed more and more over the last months and now only do topical anesthesia, tetracaine drops 3 times, and then follow with xylocaine 2% gel. Make sure it's an alcohol-free preparation. Want to cause any damage to the epithelium, and apply this multiple times over a time of 5 minutes. A lot of surgeons also do the same topical anesthesia for cataract surgery, so you're kind of familiar with that. You can consider to use a spec because it gives more access of the surface of the eye for the xylocaine gel. You can consider preoperatively to use phenylephrine or brimonidine for vasoconstriction to avoid any kind of bleeding. And especially if you do subtenon anesthesia, make sure that you don't have any bleeding at that time. So the possibility to perform MicroPulse laser treatment without any anesthesia standby and now do it in the anesthesia is an ad hoc procedure. And that avoids, first of all, in the COVID time, a second consultation in COVID time. It's probably very nice for the patient because they can have this procedure immediately. They don't have to come back to you, and they consultation. So I shifted completely to this topical anesthesia. I asked my patients, and they're kind of painful and comfortable with it. I mean, of course, they feel that you do something with the eye, they feel the movement, but they don't experience pain sensation during that time. And after the procedure, and that's very different from the G-Pro procedure, if you're familiar to that, the patient don't need any painkillers. They don't need any anti-inflammatory drugs in the first 24 hours after the procedure. It is less invasive and causes less disturbance of the tissue. So that's without these changes, you now have the option to perform MicroPulse laser treatment with or without standby of the anesthesia in a small procedure room, in the office, and ad hoc. So I want to show you one case that I have treated during the COVID times. It was one of my patients after trab. It was a moderate glaucoma case, 85-year-old lady, pseudoexfoliation glaucoma, which most of my patients here have in both eyes. She had a trab in her left eye, November 2019, with mitomycin C. She had a suture lysis. She was on 3 meds again in February this year, and the pressure was 21. So I don't call it. In between, she had a needling. It was kind of a failed trab. Very unsuccessful, very unpleasant for you as a surgeon, but things happened. So we discussed options. Well, we can do a second needling. We also can do and shift over to a glaucoma drainage device, Ahmed or Beerveld. Both could work. Maybe the second needling would not work for a long time, but the glaucoma drainage device would be a good alternative to a failed trab. The disadvantages are multiple post-op visits, and those were required during the COVID-19 pandemic, with a potential risk of infection for a patient in her mid-80s with probably a lot of comorbidities. So hence we discussed as an alternative a MicroPulse TLT. I talked to the lady, I told her that we could do the procedure, it potentially would lower the pressure, but it could lower the pressure if it's not very successful, because she was kind of scared of trying something new she was not used to or we had not so much experience with. We could do the procedure to get the pressure down, get over this COVID time, and if necessary, shift to an Ahmed valve. The settings were for the late stage, 50 seconds. For hemiplegic, I used 2,500 milliwatt in these patients, sorry, milliwatt, and the duty 0.3%. Her pressure before the treatment was 22 on 4 drugs. I did the MicroPulse treatment 20th of April, and a month later I saw the patient again and the pressure went down to 12 on 2 meds. Well, that's a 45% IOP reduction and a reduction of 2 meds. Very successful, but only 1 month post-op yet. Let's see for how long that lasts. But at least now we are mostly over this COVID period here in Switzerland, and that was our goal. Getting the pressure down, going over the COVID period, and if necessary, then do incisional surgery again. I gave her a prescription before the procedure for the post-op period. Topical antibiotics I sometimes use, especially if I don't see the patient for so long, and steroids for 1 week. And the regular post-op visits have been reduced now to 1 month, and I see her next in 3 months to check her pressure. For your attention.
Excellent. Thank you very much for this lovely talk. Marc, can I just ask you a couple of questions? They just arose here.
Yeah, sure.
So one question was the topical anesthesia. Do you use them only with the P3 probe, or can you use it also for the continuous wave, continuous wave cyclodiode?
I haven't honestly used them for the continuous wave. I expect it would not work sufficiently for continuous wave because it causes much. Look at the studies looking at temperature curves during the continuous wave procedure, they increase dramatically. With the MicroPulse treatment, the pressure stays kind of in the range where it was before, and that's the reason why we don't expect so much pain in general. Topical anesthesia is sufficient for the MicroPulse. I don't think it would be sufficient for the continuous wave procedure.
Yeah, that's my feeling as well. So what do you think about pseudoexfoliation? Does it work? I mean, you just presented a patient with pseudoexfoliation.
Yep.
It has the same effect like in primary open glaucoma.
Yeah, in our experience at the moment, it works in both types of glaucoma, in primary glaucoma, as well as pseudoexfoliation as a secondary glaucoma. We looked also at pressure profiles, 24-hour diurnal pressure curves. It lowers the pressure not only, but it also reduces the fluctuation over the. But we know all in pseudoexfoliation, we have a lot of diurnal fluctuations of pressure, and they still stay, but they get a little bit less. So that's an advantage to consider it even in pseudoexfoliation as a secondary glaucoma type.
Excellent. Thank you very much. I think later on we will have a little bit more questions to answer. So please, if you feel free to write in the chat, and we try to answer while we go. So the next will then be the next topic, the versatility of MicroPulse TLT. It will be presented by Professor Aptel, and he will talk about patient selection and also a case about cataract and MicroPulse in combination.
Yes, thank you. Hello, good afternoon, everyone. So I'm going to share my screen. So I hope that you can see my slides. So good afternoon. So thank you to the team of Iridex for your invitation. And I'm going to discuss the selection of the patient in which we can consider the use of the MicroPulse TLT. So my financial disclosure. So actually I have 3 parts in my presentation. First of all, I have a series of patients in which I did a combined cataract surgery and MicroPulse TLT, so it's that I'm going to show you. Then I will discuss the selection of the patient, and I have 3 cases showing that we can consider the MPTLT in a large variety of patients. So firstly, my series of patients with a combined cataract surgery and laser treatment. So I did that in 17 patients in the last 2 years. So here we have the demographic characteristic of the patient. So I did that mostly in open-angle glaucoma patient, 1 pigment dispersion glaucoma patient, and 4 patients with angle closure glaucoma. Most of the patients were early or moderate glaucoma, naive of any filtering surgery, and only 1/3 of the patients previously had trabeculectomy, deep sclerectomy, or mixed surgery. So the pre-op IOP was between 19 and 20 millimeters of mercury with 3 glaucoma medication. So just a word about the surgical technique. In all the patients, I did the cataract surgery first, and then I did the laser treatment. I did normal cataract surgery, 2.2 millimeter corneal incision. In most of the patients, the hydrosuture was enough to do the laser. Only in 2 patients, I had to use a nylon suture to be able to do the laser. So I do the cataract surgery with topical anesthesia, and just at the end of the surgery, I have asked the anesthetist to do a very short flash anesthesia with propofol. So we did not have to intubate the patient. We just have to check the heart rate and to check the blood saturation. So regarding the laser parameters, as you told, I use 80 to 100 seconds inferiorly and the same superiorly, and I did 5 passes per hemisphere with 2000 milliwatt. And just in some of the patients, I did a newborn examination before, for example, in highly myopic eye with big eye, and I use UBM images to choose the distance between the limbus and between and the probe. So the follow-up, I did that as ambulatory surgery, and then I have seen the patient 1 week, 1 month, 3 months, and then every 6 months after the surgery. Regarding the medication, I gave to the patient dexamethasone 4 times a day for 1 month, and non-steroidal anti-inflammatory drugs topical 4 times a day for 2 months. Regarding the hypotensive medication, actually I did not stop the hypotensive medication just after the laser. I wait at least 1 month, and when I see the IOP going down, I start to stop the medication one by one, so step by step. So here we have the efficacy. So the pre-op IOP was 19-20. We have the IOP decrease with 9 months of follow-up, and the IOP was 9 months after, a little bit less than 15 millimeters of mercury. So I had about 25% of IOP reduction. Actually, I think that it is good because I was also able to decrease the number of glaucoma medication. For example, my patient had about 3 glaucoma medication at baseline and less than 2 glaucoma medication 9 months after the surgery. So I had both a decrease of the IOP and I was able to decrease the number of glaucoma medication. So the criteria of success was at least 20% of IOP reduction without other treatment and without increase in the number of glaucoma medication, and more than 2/3 of the patients were considered as a success. And as you can see, 6 months after the combined procedure, most of the patients had an IOP below 18 millimeters of mercury. The safety profile is very good, and actually, in my opinion, the safety profile is exactly the same than the cataract surgery alone. We only had some minor side effects, sometimes a small inflammation, sometimes a small increase in the IOP. Apart from that, no hypotony, no phthisis, no decrease of visual acuity, no leakage of the corneal incision, just one choroidal detachment, but it was a small and peripheral choroidal detachment. We didn't have to do a surgery to treat the choroidal detachment. So clearly the safety profile is good, the same as the cataract surgery. And just also, this is interesting, I have checked the number of combined surgeries that I did over time. And as you can see, I've increased in the second part of 2019. And the reason could be that mitomycin was not available in France and maybe also in Europe. And also in France, the Xen implant was not available. And before that, I did a lot of combined cataract and Xen surgery. So now I continue to do that. As you told us, I think that it is convenient because of the COVID-19, we don't have a lot of surgical time. And the procedure is shorter than a combined cataract and mixed surgery. And also, we don't have to see the patient frequently. So it's good for us now. So the selection of the patient now. So as you know, in the field of glaucoma, we have a lot of techniques available to decrease IOP, surgical or non-surgical. Most of the surgical techniques use a filtering blebs to decrease IOP. As you know, with the filtering blebs, we can have a lot of issues. We can have fibrosis or healing, and the IOP is going up, so it is a failure of the surgery. Sometimes we have too much filtration. We can have hypotony, macular edema, papillar edema, and decrease of visual acuity. So when we do a filtering surgery, we have to see the patients frequently, we have to manage the bleb, we have to come back to the operating room. It's not comfortable sometimes for us and for the patients. The risk of fibrosis could be significant. For example, this is a graph of the TVT study, and if we look at the trabeculectomy arm, only 3 or 4 years after the surgery, 40 to 50% of the patients were considered as failure. Also, the safety profile of some of the filtering surgery is not good, and because of that, we can have a decrease of the visual acuity. This is also a graph of the TVT study. In white, we have the patients that have trabeculectomy. Left part, improvement of visual acuity. Middle, no change. Right part, decrease of visual acuity. And as you can see, a significant part of the patient had an important decrease of visual acuity after trabeculectomy. So as alternative, we have the cyclodestruction or cycloplasty procedure. When we look the continuous diode laser, as you told, the efficacy is good. However, the predictability of the IOP decrease is not good. We have a large variability of the IOP decrease from one patient to another patient. And also the limitation could be the safety profile. With the continuous diode laser, we can have a lot of serious complications. We can have IOP, hypotony, ocular phthisis, chronic uveitis, decrease of visual acuity. So because of that, I think that we use the continuous diode laser mostly in patients with very advanced refractory glaucoma, but I think that it could be not easy to use that in patients with early glaucoma or moderate glaucoma. So it was a study evaluating the use of the continuous diode laser in patients with good visual acuity. As you can see, in black, we have the pre-op visual acuity. In gray, we have the post-op visual acuity. Some of the patients had 20/40 or 20/60 before, but had light perception or no light perception after the laser. So, of course, we cannot use this laser in early or moderate glaucoma. So, fortunately, now we have the MicroPulse TLT, which is much better tolerated. We know from the studies that we can change, we can modulate the parameters of the treatment. So we can change, we can modulate the efficacy, the IOP decrease. We also know from the studies that the predictability of the IOP decrease is much better. For example, it was a study evaluating the relationship between the pre-op IOP and the post-op IOP. The white dots are patients with continuous diode laser, and the blue dots are patients with MicroPulse diode laser. And as you can see, the relationship, that is the predictability, is much better with the MicroPulse TLT than with the diode laser, with the continuous diode laser. Also, the safety profile is much better, and actually, the risk of hypotony, the risk of phthisis, the risk of decrease of visual acuity is very, very small after the MicroPulse diode laser, and is almost zero. So, the patient selection, I think that we can still use the MPTLT in patients with refractory glaucoma, for example, after failure of filtering surgery, in patients with neovascular glaucoma, traumatic glaucoma, fatigue glaucoma, and after vitreoretinal surgery. But maybe in this patient, we have to increase the parameters of the treatment. We can increase the duration, we can increase the power of the treatment. And because of the safety profile, I think that we can consider to use the MPTLT in patients with early and moderate glaucoma before filtering surgery, particularly in patients with tolerability issues with the medication, in patients with poor compliance with the medication, in patients with ocular surface diseases. So we know that the risk of fibrosis after filtering surgery could be high. In patients with cataract surgery, so as I told, we can combine cataract and MPTLT, and also in patients with myopic eye, because the risk of complication after filtering surgery is higher. So in all these patients, I think that we can use the MPTLT. So just to illustrate that, I have 3 clinical cases. So the first one was a 68-year-old man. He had progressive glaucoma with 3 medications. The visual acuity was good, 20 to 20, and the IOP was 22 and 23 with 3 medications. So as you can see, the visual field, he had progressive glaucoma. So in the first eye, I did a trabeculectomy 3 years ago. It was not successful. I had a leakage just after the surgery with a choroidal detachment. I had to cut some suture again, and actually 6 months after, it was not successful. The IOP was still 22 with 2 medications. So it was a failure of the trabeculectomy. So as the visual acuity was still good, I decided to do a MPTLT. So the IOP was not very high. I used 100 seconds superiorly and the same inferiorly, 2000 milliwatt. And here we can see the IOP, the post-op IOP, and actually it is pretty good. Now the IOP is between 14 with 16 with only 2 medications and no change of the visual acuity, and now no visual field progression. So the second case is, it was a 71-year-old man. It was a very advanced glaucoma. IOP was very high with 4 medications. And as you can see, the ocular surface is very bad. The conjunctiva is red, is thick. So I was thinking that the risk of fibrosis of a filtering blade was very high. So I decided to do an MPTLT treatment. Because the IOP was very high, I did 120 seconds superiorly and 120 inferiorly. So long duration, 2000 milliwatt, and it was successful. As you can see, the IOP is now low and just 1 medication, and because of that, the ocular surface is much better because we were able to decrease the number of glaucoma medication. So the last one, it is also a 78-year-old man with angle closure glaucoma and cataract. The IOP was 25 and 27 with 1 prostaglandin. As you can see, we have a pupillary block. We have a pupillary block with angle closure. So I decided to do a combined cataract and MPTLT treatment. The IOP was not very high, so I used 80 seconds inferiorly and superiorly, 2000 milliwatt. And now the IOP is 17, 18 without medication, so it was successful. So of course, we have an opening of the angle, so we can think that the IOP decrease for one part is due to the cataract surgery, but clearly I think that the combined treatment cataract plus MPTLT is more efficient to decrease the IOP than the cataract surgery alone. Thank you.
Excellent, thank you very much. So there are some questions. You just mentioned the combined cataract and MicroPulse laser. So people were asking, really, do you do the cataract surgery then with topical anesthesia, or do you do a block?
Yes, topical anesthesia. And just at the end of the cataract, I asked to the anesthetist to inject a little bit of propofol. So I did a flash anesthesia for the laser. But for the cataract, only topical with drops of tetracaine, ciprocane.
There are a couple of questions, people mentioning that they tried topical actually, and with MicroPulse, and the patient, they had pain. So what recommendation do you have for them?
Yes, I had the same. At the beginning, I tried with only topical, and actually during the treatment, some of the patients feel some pain. So I think that if we are in an operating room, we have an anesthetist, we can ask to inject a little bit of drugs to complete the anesthesia. But I agree, topical anesthesia for me alone, I think is not enough. So maybe a block, or maybe a very flash anesthesia, but not topical anesthesia alone.
Excellent. There are some more questions we will answer maybe later on. Thank you.
Thank you.
So the next then please will be Ronald De Crom, and he will talk about the overview of studies and data in the Netherlands, and also about MicroPulse after implants.
Yeah, thank you, Mark. Yeah, good evening, everyone. I will have some small literature overview of some famous articles, some information of our own studies in our hospital, and I will show you some various cases. These are my financial disclosures. If we look at the literature, and if we look at the articles which are published with the topic of MicroPulse laser treatment, you can see that the last 3 years there is a lot of publishing data available, and there are a lot of articles, some small studies, some bigger studies. But I think for every glaucoma doctor, and also nowadays for the glaucoma patients, there are 3 important questions which we can ask to ourselves, especially for this treatment. So what is the IOP lowering effect? What's the effect of the treatment on the medication? And how safe is this procedure? We always have to take in mind that a lot of things are dependable about power and duration of the treatment. If you lose a lot of power, or if you treat it for a long period, it has effect on the treatment effect by itself, but also at the complication rate. So for this study selection, I make some criteria like the normal powers, which are mainly used, are 2000 to 2500 milliwatts, the duration 80 to 120 seconds. And I take also some larger studies with more than 50 patients. And if we look at these 3 questions, and if we look at some studies with bigger patient populations, then you see that the effect of MicroPulse laser treatment after 1 year is around 30 to 46% of IOP reduction, quite a lot. And also, if I look at our own data, our data is going to be published in the Journal of Glaucoma, and it's a data set of more than 140 patients. And we see after 1 year and after 2 years of stable IOP reduction from around 30% of mercury. If you also look at the medication reduction rate, also if you see the largest studies and the data in that study populations, after 1 year, you can see that there is a mean IOP reduction of 0.6 to 1.6 in number of medications. And also in our own data, we see the same. After 1 year and 2 years after MicroPulse laser treatment, there is a stable reduction in number of medications. Most important question for all of our glaucoma treatments is the fact by what is the safety of the procedure, what is the effect on visual acuity, what is the effect on other things of the eye. And also, if you look at the studies which investigated the visual acuity, then you can see that after 3 to 12 months after the procedure, there is some decline in visual acuity of more than 2 lines in 40 to 20%. And also in our own data, we can see that after 2 years after treatment, in 25% of the patients, there is a decline of visual acuity of more than 2 lines. Is a lot if you see so. We just saw that also after trabeculectomies and implant surgery, there is also a decline in visual acuity. And for all the studies, we can see that the visual acuity decline is mainly due to cataract, pre-existent retinal diseases, or glaucoma progression in this period. If we look at other complications, then we can see that mild anterior chamber inflammation is a frequent thing we can see post-operative, also with transient keratopathy. That are the 2 mainly things we can see in the post-operative phase. Other things like hypertony, macular edema, persistent mydriasis, you can see it's not frequently seen after the procedure. No big events like phthisis or choroidal hemorrhages are present in the studies. Also in our own data, we can see that the complication rate of the treatment is very low, and most of the complications are transient. We saw it only in the first year in 5 of the 141 patients. So if you see the literature, then you can see that the MicroPulse laser treatment is a very safe and effective treatment for both lowering the IOP and also decreasing the number of medications people use. I want to also present you some cases of patients who visited our academic university clinic. And the treatment we standardized use is in treatment with subtenal anesthesia. Nowadays we use the neuroprobe, but for these cases we all use the MicroPulse original P3 probe, and we treated the inferior and superior parts with exception of the 3 and 9 o'clock areas and the trap or implant areas, with a duration of 80 till 90 seconds. We always start with primary treatments with 2000 milliwatts, and you perform some 5 passes per hemisphere. Postoperative, we use some steroids, and glaucoma medication will be withdrawn if appropriate. And mostly we see the patients 1 week or 1 month after the treatment. And the first case was a man with traumatic eye injury, also neovascular glaucoma, and a prior cryotherapy of the ciliary body. It was a blind eye, an IOP of 28, which is quite acceptable, but this patient had a lot of complaints of his glaucoma medication. So we performed a laser treatment, and you can see a very quick response within the first week, and also after 1 month, a very nice IOP. So we stopped the IOP medication, and you can see 1 year and 2 years after the treatment, he still has a very nice IOP without any medication. Second case I want to present you is a male of 36 years old with congenital cataract and an aphakic lens status, prior retinal detachment, in which he has received a vitrectomy, and also a neovascular glaucoma, very high pressure with a lot of medication, and it is not a quite attractive eye to perform glaucoma surgery on it, aphakic status after vitrectomy. So we performed a cyclolaser in this patient, and you can see also in this patient a very quick response, and 1 year after the treatment, an IOP of 90 with less medication. has this nice IOP, he still has complaints about his medication, so we performed a second cyclo laser, and the IOP went very low at 3 millimeters of mercury, without medication, with no complaints, no signs of capitotonous maculopathy, and the patient is now very happy with this situation. Also, after implants, you can use this laser treatment. So in this case, we have a 78-year-old female with a pseudophakic lens status and a Barveld implant in her eye. Very good visual acuity and an IOP of 80 under tafluprost medication. Also here we performed the laser treatment, and also in this case you can see a very quick response to the IOP. And even 2 years later, you see an IOP of 11 with tafluprost. There was another case of a patient with a Barveld implant, an IOP of 80 with a lot of medication. And also in this patient, you can see that if we perform a cyclo laser, you can see a very good effect on the IOP and also in the reduction on medication. As we are now 2 years after the treatment, an IOP of 6 with still some medication. Also, after a failed Xen implant, you can always argue with patients, what are we going to do? Do we perform a needling or not, or do we perform a second treatment? This female patient already underwent a needling procedure and she didn't want any other surgery. She had a very good visual acuity and an IOP of 27. So also in this patient, we performed a cyclo laser, and you can see good IOP after 1 week, 1 year, and also 1.5 years later. He had an IOP of 10 with some medication. Also, after failed in focus microshunts, you can use the cyclo laser very good. So in this case, a female patient of 77 years old with an IOP of 34, quite a lot of medication. And also this patient didn't want at that moment further surgery. So we performed a cyclo treatment, and you can see an IOP of 20, 2 months after the treatment with less medication. But we still wanted to go a little bit lower with the IOP. So we performed a second treatment. And 1 year after the second treatment, she has a very good IOP of 12 with some medication. And if you go to the last case, in summary, we already told that the treatment with the MicroPulse laser is very safe and effective, and you can also consider it in patients after failed glaucoma surgery or patients who are at higher risk for incisional surgery. Thank you for your attention.
Thank you very much. Excellent talk. So there, maybe we can address that first. So there were some questions about the visual loss. Why do you think patients lose their vision with the cyclodiode, really? Is that something that is permanent or something just for a while?
Yeah, if we look, most of the patients experience some transient vision loss in the first period after the laser, but within a month, most patients don't have any complaints anymore. If we look at our data and also in the studies, there is a part of the patients who has experienced loss of visual acuity, mainly due to cataract formation or prior diseases, especially patients with prior retinal disease. You have to be aware of the developing of macular edema or something like that. But Most of the times there are no very large patient numbers with complaints at a longer period.
Yeah, that's a good point with the cystoid macular edema. Maybe we just open now the question and answers round. So what do you experience with the cystoid macular edema? Is that something you often happens really, and give you non-steroidal antiphlogistics like Acula or any eye drops?
If I look at our data from the 150 patients, I think 2 patients developed macular edema, and they were all patients with prior retinal disease. And all of that patients which developed macular edema, it went away after some steroid use of drugs.
Yes. And so then there was the question, do you what the people say, do you perform cataract surgery first or laser treatment first when you combine them? Maybe this is something for Dr. Aptel. So which one do you do first? Is it cataract or the laser?
So I did the cataract first and the laser after. I don't have any issues with the shutter. It is possible to put the probe on the eye. I didn't have any opening of the shutter. So cataract and then laser. Cataract and laser.
Mm-hmm. And so there were some questions about repeat procedures. So how often can you repeat the procedures? How long does the effect really last like? And how often can you repeat the procedures? Can you do it a couple of times? And so what is your opinion about that? Maybe some ideas?
Question. If we look at the data or the video that we showed in the beginning from Murray Johnston, the MP3 treatment is actually not destroying any tissue. So having that in mind, theoretically, you can repeat the treatment endless times. In my experience, I think I've done the most often the patient was 3 times, and it always worked. It's very, well, there's a lot of look between different patients for how long the treatment works. We've seen a couple of cases presented by you today, works for 2 years, which is a really, really good result. We have patients where the treatment fails after months 3 to 6. I think at the moment there is no general statement possible for how long the treatment works, because we have this variation and we don't have so much data yet to really answer the question of long-term success. But definitely you can repeat the treatment, and I would definitely do it a 2nd time. I would also do it a 3rd time. And if we gain more information and more data in the future, we will probably do a 4th and a 5th treatment over a long-term course of patients, especially now that we start to treat patients earlier in the disease stage.
Yeah. And then there was this question, can you do first MicroPulse laser and then do later on a filtering surgery? Is that possible? I think that's something which is also an interesting question in COVID times, because sometimes, you know, in COVID times you can't do filtering surgery in many patients, and maybe that will help you then to leave them for a while stable and then do a filtering surgery later on. What is your feeling about it?
That's also a good question. If you think back to the continuous wave treatment with a G-probe, and you did it in a couple of eyes and you opened the conjunctiva later, you could really saw the burn marks from the laser in some cases. And you had problems at this areas to open the conjunctiva because of scarring. With the MP3, even before COVID, I've done cases with an MP3 first and then later went over to fistulizing surgery. And you don't have all these scarring with the conjunctiva in these cases. And I think especially with the revised handpiece, which is much smoother on the surface of the globe, you cause less bleeding, and you will probably also cause less scarring by that. And keep in mind, you have less energy by the MicroPulse. It chops up the whole energy in smaller portions. So I think you can definitely do the MicroPulse later on due trabeculectomy or tubes.
Yes, I agree. No thermal effect on the conjunctiva, no scarring, and there is no issue. We can do that. The conjunctiva is very nice after MP-TLT treatment. No problem.
Yeah. And then there were questions about indications, different glaucoma types after vitreoretinal surgery. In angle closure glaucoma, can you do it? And what about inflammatory glaucoma, so like within uveitis? Or is there any contraindication where you say, no, these kind of patients are really not for laser? Is there anyone who wants to address that?
Yeah, if I look at our data and our patient categories, patients after vitrectomy, especially vitrectomy with oil, we see a lot of good results in those patients. Uveitic patients we also treat, but it depends on how active the uveitis is and what kind of uveitis it is. So you have to be aware of more inflammation in, especially in uveitic patients. You can treat them, but it depends on the degree of uveitis.
Yes. Something maybe we'd like to mention is about the anesthesia forms. Sometimes in the talks I saw that you do subtenons anesthesia. I have to say you need to be careful because there can be some bleeding under the subconjunctiva with subtenons anesthesia, and then the laser, in my opinion, is not working very well because of the absorption. How do you do the subtenons then to avoid the bleeding?
We've got very good anesthesiologists, so.
Interesting. Excellent.
But if you have a very gemotic conjunctiva or a lot of bleeding, that's not good for performing a good treatment. So you have to be aware of that.
Maybe to add again, a drop of brimonidine can help to avoid bleeding. And if you do subconjunctival anesthesia, try to stay away from the limbus, and then use some kind of instrument like a spatula to squeeze the anesthesia away from the limbus immediately. And even if you have a small bleeding, if you put some pressure with a glass spatula on it, you can compress the bleeding and avoid that it comes to the limbus and keep it far away from the limbus so that you still have areas that you can treat without bleeding.
That's a good point with brimonidine for vasoconstriction, and then it's easier. Is there any case where you wouldn't do MicroPulse laser?
No, I don't think. No, there is no contraindication. Maybe, of course, in angle closure glaucoma, we have to do that with cataract surgery or to do a laser iridotomy first. But for me, no, there is no contraindication. And I agree, for a patient with uveitis glaucoma, it is possible. If there is no activity of the uveitis, we can do that. So for me, no contraindication.
I agree with that. In adult cases, you can consider MicroPulse in nearly all kinds of glaucomas. I would be careful with uveitic glaucoma as well, but if you have to do a laser in uveitic glaucoma, I would prefer the MicroPulse over the continuous wave probe, because there you definitely have more inflammation. Not contraindication, but an indication where I would be really careful is congenital glaucoma, because at the moment the results show that the effect of MicroPulse in congenital glaucoma is not that long. But keep in mind, it's a difficult to treat disease anyway. And if you have a case and you can treat the glaucoma with a MicroPulse for a couple of months, having in mind that you have to do something else later, it can be an option. But don't think that the MicroPulse in these really, really difficult young patients can solve the whole problem. It's one step to it, but the results show it's not so long lasting as it would be in an adult case. So that's the only thing that I wouldn't mention as a contraindication, but at least as something where the results at the moment are not so promising as we have seen them with adults, but it still works.
I agree. So in congenital glaucoma, we do trabeculotomy, and if you need to do really cyclodiode, then the continuous wave. Yeah. What else? So then there's the question: will the G probe become obsolete? So do we just use the MicroPulse now?
No, in some forms of glaucoma with very high IOP or very low visual acuity, for example, neovascular glaucoma, aphakic glaucoma, I still use the G probe. So of course I use less the G probe now, but still in some patients.
And what about, do you adjust the energy levels depending on the height of intraocular pressure or of the stage of glaucoma? So, and what do you really adjust then?
I adjust the duration, but usually not the power. So I change the duration of the treatment for each hemisphere, depending on the type of glaucoma, the pre-op IOP, and the number of glaucoma medication, and of course the stage of glaucoma.
Maybe to add from my point of view, personal statement, it's only my feeling, I changed the power a little bit on the stage of glaucoma. Yes, for early cases, I stay more on the lower side of the power. For advanced cases, maybe after a failed trabeculectomy, a failed tube, I would add a little bit more power and increase the power, but not the time and not the number of swipes.
Yeah, I do that as well. So in mild glaucoma cases, like for example, in keratoconus patients, I use 2000 milliwatt, and for moderate, I use more like 2250, and for severe, or that's in the hospital, most of the cases, unfortunately, 2500 milliwatt. Yeah.
Also, the pause time is very important. So we see that if you make your passes too quick, it has a negative effect on your laser treatment. So you have to be aware of the duration of your passes per hemisphere.
That's quite interesting. Can you maybe explain that a little bit more about the passes you do with the MicroPulse probe? So how quick are you doing the swipes?
Yeah, if you make a pass on a hemisphere, you at least need minimum 10 seconds to perform one pass. If you go too fast, yeah, you can see, if you can have an less treatment effect of the laser treatment. So most of the time, if you treat a total of 80 seconds, 5 or 6 passes is most of the time 5 passes is a good number of passes to deliver the laser energy.
Excellent. And another question: how would you approach hypotony post laser, and does it resolve on its own, or what actions do you then do?
Well, it is not common. Of course, first of all, we have to stop the glaucoma medication, and then maybe we can wait a little bit, and we can give dexamethasone or corticosteroid eye drops to the patients. But we don't have a lot of patients with very low IOP after MPTLT. It's not common.
And then this is maybe a little bit connected. Do you dilate the pupil after the treatment? Because some people, some surgeons, they give atropine at the end of surgery. Some do it for inflammation, and some do it for like the ciliary pain. afterwards. So what about dilating the pupil?
No, I don't.
I also don't dilate the pupil. No.
I'm conservative. I still do it, but it comes from continuous wave treatment. I don't really think it is necessary, but it's like what we did in the past. 1 drop of atropine at the end of the procedure, like that we did after the continuous wave treatment. Yeah.
Yeah, with the MicroPulse treatment, we see that patients most of the time don't have any pain complaints. So giving atropine for pain reduction, I think it's not necessary. And inflammatory reasons, we don't see a lot of big inflammations in the first week. So for the older G-probe procedures, yes, it's suitable for, but for the MicroPulse laser, we don't use it in our clinic.
Excellent. I think that's quite a lot of questions we already answered. Is there anything you want to add to this round?
Can I maybe add one thing to the question about the anesthesia before, because we had some contradictory statements. Professor Aptel said like topical anesthesia for him didn't work, and he referred that to just eye drops. My statement about topical anesthesia, and maybe in the future we'll call it topical plus, is topical anesthesia made out of eye drops, and then for 5 minutes is xylocaine gel. And I think that's makes a difference as a topical treatment. So topical is probably not sufficient, but topical plus can work.
That's a good point. One more question came in. What about dilated pupil as a complication? How you address that?
That's a good question. After the MPTLT, you see some dilation of the pupil, lasts for a couple of weeks. All pupils that I saw that are mildly dilated after the treatment came back to its normal diameter after a couple of weeks. So I wouldn't say it's an issue for more than maybe 2-3 months. But yeah, that can happen, especially if you just treat one eye. You see a small difference between both pupils if you look at the diameter.
Do you give pilocarpine?
No. Because pilocarpine actually can cause some headaches, and patients are not happy and satisfied if you cause headaches to them. And none of them ever complained about the dilated pupil causing more sensitivity to light or so. It's really a slight dilation. It's not a full dilation.
So there was a question as well. Is this course available later online? And yes, so later today, Iridex just mentioned it will be online, and in a few days also on YouTube available, just to let you know. Yeah, any more points to discuss? I think this is a very interesting discussion, and I think we had a lot of answers. Let's see if there's anything more. A couple of times people ask if you can use the probe for different patients. So we are not doing that. I think it's not legally, but any comments on that? Can you use the probe on different patients?
Well, it's definitely an off-label use, and I can't recommend. Probe is meant to be used once.
Yes.
If you look at the original P3 probe, you can see in some patients that in the laser channel there can be some bleeding in it from a patient. So we always use a new probe for every patient. just because the risk of contamination of that kind of material.
And also for efficacy of the laser. I mean, if you kind of have to sterilize the probe between patients and you use alcohol, it's a plastic material, and plastic and alcohol don't go well with another. So you have small scratches and small issues with the probe if you use alcohol on it between two patients, and then the laser light is not bundled anymore, it's not straight, so you lose efficacy. And again, even with the G probe, it was not intended to be used twice. So
when do you strip off glaucoma medications following MicroPulse? I think Professor Aptel already mentioned after a month he will start to reduce medication.
Yes, I think at least 1 month, because at the beginning we have the inflammation, we have the effect of the steroid, so we don't know. Usually I wait 1 month to begin to decrease the medication, and I wait 2 to 3 months before deciding to do a second treatment sometimes.
Perfect. Then there's a question, what is the cost of treatment at private clinics? I cannot make any comment to that. Okay, so I think we come to the end. Thank you for having all of you here in the webinar, which is a quite interesting new version of a conference. And yes, so hopefully we will see in person at some point. So we see how it goes. So thank you very much for everybody.
Sure.